Welcome back to Rad-On Smart Review, RadBio edition.
Great to be here. Today, we're tackling some really critical normal tissues.
We're diving into the late effects of radiation on the heart, the kidneys, and the lens of the eye.
Yeah, exactly. And this is all about giving you, the resident listening, a really targeted, kind of high-yield review.
We want to hit those key radiobiological concepts, things that are just crucial, not just for exams, obviously, but, for day-to-day clinical decisions, for long-term patient care.
Absolutely, because understanding how radiation affects these organs years, maybe even decades later,
Mhm.
well, it fundamentally shapes how we approach treatment.
It impacts contouring, technique choices, the dose constraints we absolutely have to respect.
It really does. So where should we start? Maybe the heart.
Sounds good. Historically, the heart was sort of thought of as pretty resistant to radiation, wasn't it?
Yeah, that was the older view, decades ago.
Hmm.
But our understanding has definitely evolved quite a bit.
So it's not resistant.
No, not really. We now know the heart is definitely susceptible to significant late effects. We group these together often as radiation-induced heart disease.
And that word late is key here, isn't it? These aren't things we typically see right after treatment finishes.
Precisely. You're talking years, sometimes 20, maybe even more years down the road.
And clinically, where do we see this risk?
Well, situations like left-sided breast cancer, obviously, or mediastinal lymphoma, especially with older mantle fields, lung cancer, esophageal cancer too, anywhere the heart might be in the field.
So, biologically speaking, what's the starting point? What's the main cellular target that kicks off this damage cascade in the heart?
Well, the evidence points strongly towards the endothelial cells, the cells lining the tiny blood vessels, the microvasculature, and also the bigger coronary arteries.
Okay, the lining of the blood vessels.
Right. When radiation damages those cells, it sort of sets off this whole chain reaction of inflammation and eventually fibrotic processes, scarring, basically.
So damage leads to inflammation. Inflammation leads to scarring. Makes sense.
Exactly. And it's that chronic inflammation and fibrosis that can then affect different parts of the heart muscle or structures,
Yeah.
leading to all the different ways it can show up clinically.
Okay, let's talk about those clinical manifestations then. What are the main types of radiation-induced heart disease we see?
One of the more common ones, clinically speaking, is pericardial disease. Now, you can get acute pericarditis soon after RT, but the late effect we're really focused on is that delayed or chronic pericarditis.
And that comes much later.
Yeah, months too, often, many years later. It's driven by that slow burn of chronic inflammation and scarring in the pericardium, the sac around the heart.
And what does that cause?
It can lead to fluid buildup and effusion, or more seriously, the sac can thicken and harden, which restricts the heart's filling. That's constrictive pericarditis.
Ah, so the scarring physically restricts the heart.
Exactly. It's the progressive nature of that fibrosis over time.
Okay. What about damage to the heart muscle itself?
That's myocardial damage or cardiomyopathy. Again, typically takes years to develop.
And the mechanism there? Still fibrosis.
Yeah, it's often characterized by diffuse fibrosis within the heart muscle itself, making it stiff. Clinically, this often starts as diastolic dysfunction, meaning the heart struggles to relax and fill properly.
Okay.
And then over time, it can progress to systolic dysfunction where the pumping function itself is impaired.
Right.
That leads to heart failure symptoms. And that damage to the small blood vessels we mentioned earlier definitely contributes here too.
Got it. And then there's the big one. Everyone worries about the coronary arteries.
Right. Radiation-induced coronary artery disease, or CAD.
Yeah.
That's a major concern. It often shows up maybe a decade or two after treatment.
How does radiation affect the coronary artery specifically?
It seems to accelerate the whole atherosclerotic process. Remember that initial endothelial cell damage?
Mm-hmm.
Well, that injury to the vessel lining promotes inflammation and helps plaque build up faster, leading to narrowing and increasing the risk for things like angina or even a heart attack.
So it's almost like radiation hits the fast-forward button on developing atherosclerosis in that specific irradiated area.
That's a pretty good way to think about it, yeah. By injuring the lining and fueling that inflammation.
Are other parts of the heart structure also vulnerable?
Yes. You can also see valvular dysfunction, again, usually years later. This typically involves fibrosis and thickening of the valve leaflets.
Leading to?
It could lead to stenosis, where the valve doesn't open properly, or regurgitation, where it leaks. It's probably less common than pericardial or myocardial issues, but it's definitely something we see.
Okay.
And less frequently, the fibrosis can actually mess with the heart's electrical conduction system.
Ah, so arrhythmias.
Yeah, arrhythmias or even heart block.
Wow. So quite a range of potential issues, but they all seem to trace back to that initial endothelial damage and the subsequent inflammation and fibrosis over a long time.
That's the core theme, yes. That chronic, progressive inflammatory and fibrotic response is what ultimately causes the clinical problems years later.
Okay, let's pivot now to the kidneys. How sensitive are they to radiation?
The kidneys are definitely considered radiosensitive organs. Exposure can lead to radiation nephropathy.
Which
Yeah, basically it's a progressive decline in kidney function, and it's a classic late effect.
And what's the timeline for nephropathy? Also delayed.
Very much delayed. You might see some temporary changes earlier on, but the clinically significant nephropathy usually shows up months to years after treatment is done.
I've heard the term acute radiation nephritis. Is that different?
Well, that term is sometimes used for problems appearing maybe 6 to 12 months out, but honestly, it's a bit of a misnomer. It's not like an acute infection. It's really part of the whole spectrum leading towards chronic damage.
Right.
The truly chronic radiation nephropathy develops more like 1 to 5 years later, or sometimes even longer. It's a slow process.
Got it. And the kidneys complex. Does the radiation damage specific parts more than others?
It does. The pathophysiology is quite intricate. It involves multiple kidney components. You get damage to the glomeruli, the main filtering units,
How so?
injury to the endothelial cells within the glomeruli, and also to the podocytes, those specialized cells. This leads to scarring, which we call glomerulosclerosis.
And that impairs filtration.
Exactly. It messes up the filtration process and often causes protein to leak into the urine. That's proteinuria.
Okay. What about the tubules, the parts that reabsorb things?
They get hit too. You see atrophy, basically shrinking and loss of the tubular epithelial cells. This impairs their job of reabsorbing what the body needs and secreting waste products.
And the tissue between all these structures, the interstitium?
Ah, yes, the interstitium is heavily involved. Progressive scarring there, interstitial fibrosis, is really a hallmark of chronic radiation nephropathy.
Is that also driven by inflammation?
Yes, chronic inflammation plays a big role, along with the release of certain signaling molecules, cytokines. A key one here is transforming growth factor beta, or TGF-beta.
TGF-beta? We hear about that in fibrosis elsewhere, too.
Absolutely. It's a central player in promoting scar tissue formation in many organs, and it's definitely a major contributor to the interstitial scarring in radiation nephropathy.
And what about the blood vessels within the kidney itself?
Vascular damage is also crucial. You see thickening and narrowing of the small arteries and arterioles. There's a specific term for it. Endarteritis obliterans.
Endarteritis obliterans. Okay.
Right. And this narrowing reduces blood flow, causing ischemia, which further damages the kidney tissue. It also frequently causes or worsens hypertension, high blood pressure.
Ah, so you get this kind of vicious cycle going. Vascular damage leads to poor blood flow, which contributes to more scarring. And then the hypertension makes everything worse.
Exactly. It's like multiple hits across all the different structures of the kidney.
Given all that going on pathologically, how does radiation nephropathy actually show up clinically? What do patients experience?
It's often quite insidious, meaning it creeps up slowly. Initially, you might just pick up signs like proteinuria on routine urine tests.
Okay.
Hypertension is very common, often quite significant, and it can actually be one of the first presenting signs.
Really? Prominent hypertension.
Yeah. And as the damage gets worse, you see a steady decline in the glomerular filtration rate, the GFR, which is our main measure of kidney function.
So kidney function just gradually gets worse.
Right. Anemia can also develop because the damaged kidney doesn't produce enough erythropoietin, the hormone that stimulates red blood cell production.
And the endpoint.
Well, ultimately, it can progress to chronic kidney disease, and in severe cases, end-stage renal failure, needing dialysis or a transplant.
So monitoring GFR and checking for proteinuria in patients who've had radiation near their kidneys is absolutely essential.
Absolutely critical. It's how we track for this and monitor its progression if it occurs.
Okay. Let's shift gears now. Move up to the head and look at the lens of the eye. This is a classic, right? Highly radiosensitive for a specific late effect.
It absolutely is. The lens is famously susceptible to radiation-induced cataracts. It's a prime example of what we call a late deterministic effect.
Meaning there's a threshold dose.
Exactly. Below a certain dose, you don't expect it. Above it, the risk increases, and the severity often relates to the dose.
So how does radiation actually cause a cataract? What's the specific biological pathway?
It's actually a fascinating and pretty well understood mechanism. The key thing to remember is the lens doesn't have blood vessels. It gets nutrients from the fluid around it.
Right.
but it does have a layer of epithelial cells.
Hmm.
And critically, right near the lens equator, in what's called the germinative zone, there's a population of actively dividing sort of stem-like cells. These are the primary targets.
Ah, the dividing cells are the sensitive ones.
Precisely. Radiation damages the DNA in these dividing cells. But here's the unique part. Many of these damaged cells don't just die off immediately.
They survive.
They often survive the initial hit, but they're damaged. They become dysfunctional. Normally, these cells divide, then differentiate into very organized lens fibers that migrate towards the center of the lens.
Okay.
But the radiation-damaged cells, they differentiate abnormally. And instead of migrating neatly, they migrate irregularly, specifically towards the posterior pole of the lens, right underneath the capsule.
So they end up accumulating at the back of the lens.
Exactly. They pile up there at the posterior pole. They often look swollen or vacuolated, and they're completely disorganized.
And that's what causes the opacity.
Yes. This clump of abnormal cells and their damaged proteins, the crystallins, they scatter light instead of letting it pass through clearly.
And that light scattering is the cataract we see.
Precisely. And because they accumulate right there at the back under the capsule, it leads to that very characteristic appearance, the posterior subcapsular cataract.
Posterior subcapsular. So the location is key.
It is. It's key to its clinical effect on vision and how it looks when we examine the eye.
That's a really important point. Damage happens to dividing cells at the equator, but the visible cataract forms from their messed up migration and pile up at the posterior pole.
It really is the defining mechanism for radiation cataracts.
Let's talk dose thresholds for the lens. You mentioned it's deterministic.
Yeah.
But I know this is an area where things have changed recently, right?
Oh, absolutely. This has been a significant evolution in our understanding. So yes, the lens is a classic tissue with a dose threshold. Historically, based on older data, mostly from single high-dose exposures,
Like from therapy.
yeah, or accidents, the threshold for seeing any opacity after a single acute dose was thought to be around 2 gray.
2 gray. Okay.
And we also knew that the lens benefits a lot from fractionation. It can tolerate a much higher total dose if it's given in small daily chunks.
But that threshold has been revised downwards by the ICRP?
Yes, the International Commission on Radiological Protection took a hard look at more recent data. This included long-term follow-up from populations exposed to lower doses,
Like who?
like the A-bomb survivors, and also occupational exposure data, particularly from interventional radiologists who get chronic low-dose exposure near their eyes.
Ah, interesting.
Plus, they factored in that we now have much more sensitive diagnostic tools. We can detect really subtle lens changes earlier than before.
So combining all that,
Yeah.
what did they conclude?
Based on all this evidence, they concluded that observable opacities can actually occur at lower acute doses than we previously thought.
How low? What's the new number we need to know?
The revised acute dose threshold they're recommending now is approximately 0.5 gray.
0.5. Wow, that's a big drop from 2 grays.
It's a 4-fold decrease. It's quite significant. They also updated the occupational limits for the lens based on this, suggesting an equivalent dose limit of 20 millisieverts per year, averaged over 5 years, and no more than 50 millisieverts in any single year.
0.5 gray acute. That really changes the game, doesn't it? It means even doses we might have considered low scatter could be relevant for cataract risk.
It fundamentally shifts how we need to think about lens dose, absolutely, both occupationally and for patients where the eye is anywhere near the treatment field.
Does the dose also affect when the cataract might appear, the latency period?
Yes, definitely. The latency period is inversely related to the dose. Higher doses tend to cause cataracts to show up faster.
And lower doses take longer.
Right. Lower doses generally have longer latency periods. The range is really wide. It could be anywhere from 6 months after a very high dose to maybe 35 years or more after lower doses.
Do you have any examples?
Yeah, the source material gives some rough averages, like doses in the maybe 2.5 to 6.5 gray range might have an average latency of around 8 years. But if you get higher doses, say 6.5 to 11.5 gray, that average latency might shorten to around 4 years.
Okay, so dose matters for if a cataract forms because of the threshold and also how quickly it forms, influencing the latency.
Exactly right. Both aspects are dose dependent.
Okay, let's pull this all together now for clinical practice. How does knowing all this biology about the heart, kidney, and lens actually guide us when we're planning treatments?
Well, understanding these potential late effects is just paramount during treatment planning. It absolutely dictates the dose constraints we set and often influences the techniques we choose to use.
So what are some of those key dose constraints we're really watching for these organs?
Okay, For the heart, we're typically very focused on the mean heart dose. And also, the volume that gets higher doses, common constraints, are like V25, the volume getting 25 gray, or maybe V30.
And the goal is?
The goal is to keep these metrics below established recommended limits, especially when treating things like left-sided breast or mediastinal disease to minimize that long-term cardiac risk.
Makes sense. What about for the kidneys?
For the kidneys, the critical constraints usually revolve around the mean kidney dose and maybe V20, the volume getting 20 gray.
And exceeding those increases risk.
Significantly increases the risk of radiation nephropathy down the line, yes. So we try very hard to spare as much functional kidney volume as possible.
And now, with that lower threshold for the lens, what does that mean for planning?
Yeah, that revised 0.5 gray acute threshold really ups the ante on prevention. When we're treating anywhere near the eye, head and neck cancers, some brain tumors, it means we need to be incredibly meticulous.
How so?
Using physical shielding if possible, or really leveraging advanced techniques like IMRT or VMAT to sharply sculpt the dose away from the lens. That low threshold means even scattered dose, which maybe we didn't worry about as much before, needs careful consideration.
This all seems to tie back nicely to some core radiobiology principles, particularly the alpha-beta ratio concept for late effects. How does that fit in here?
Oh, that's a hugely important connection. For late effects, the heart, the kidney, and the lens are all generally considered to have low alpha-beta ratios.
Low alpha-beta. Remind us what that signifies about tissue sensitivity.
Okay, so a low alpha-beta ratio means that the tissue is particularly sensitive to the size of the individual radiation dose fraction.
More sensitive to bigger fractions.
Exactly. Compared to tissues with high alpha-beta ratios, like tumors or acutely responding tissues, these low alpha-beta normal tissues experience a disproportionately larger biological effect when you use larger doses per fraction.
So this has big implications for hypofractionation, right? Using fewer, larger daily doses.
Massive implications. It means hypofractionation inherently carries a higher risk of late toxicity in organs like the heart, kidney, or lens compared to conventional fractionation delivering the same total dose if those organs are in the treatment field.
So we need to be extra cautious with hyperfractionation near these organs?
Precisely. It requires very careful planning, possibly adjusting the total dose downwards, and adhering strictly, maybe even more strictly, to dose constraints for these low alpha-beta organs to mitigate that increased risk per fraction.
Okay, this has been a great deep dive into the biology. Let's try to distill this down now. What are some super high-yield clinical pearls that residents absolutely need to lock down?
All right, clinical pearls. Let's do it. Pearl number 1. Radiation-induced heart disease isn't one thing. It's a spectrum. Remember, pericarditis, cardiomyopathy, CAD, valvular issues, conduction problems. The root is endothelial cell damage leading to chronic inflammation and fibrosis over years. And clinically, delayed pericarditis, maybe with effusion or constriction, is probably the most common one we see manifest.
Got it. Pearl number 2.
Pearl number 2, radiation nephropathy. It's progressive, it's delayed. Think widespread damage glomeruli, tubules, interstitium with that TGF-beta-driven fibrosis, and those small vessels with endarteritis obliterans. Clinically, look out for that prominent hypertension and the gradual decline in kidney function leading towards chronic kidney disease.
Excellent. Pearl 3.
Pearl number 3, radiation cataracts. The key is they're almost always posterior subcapsular. Why? Damage to those dividing epithelial cells at the equator's germinative zone, followed by their abnormal migration and pileup at the posterior pole. And crucially, remember that newly revised, much lower ICRP acute dose threshold, approximately 0.5 gray. That's a critical update.
Okay, and one more.
Pearl number 4. Don't forget the alpha-beta ratios, heart, kidney, lens, generally low alpha-beta for late effects. This makes them super sensitive to fraction size. Absolutely critical knowledge when you're thinking about planning or evaluating hypofractionated radiotherapy regimens near these organs.
Fantastic summary. Those really link the underlying biology directly to clinical relevance.
That's the goal, connecting the why to the what we do.
All right, you ready for a quick board review blitz based on what we've covered?
Let's do it. Fire away.
Okay, question 1. A patient develops pericardial effusion and clear signs of constrictive pericarditis about 5 years after they received mantle field radiotherapy for Hodgkin lymphoma. This clinical picture is most likely a manifestation of A. Acute pericarditis, B. Radiation-induced coronary artery disease, C. Delayed or chronic radiation pericarditis, or D. Radiation-induced cardiomyopathy.
Okay. 5 years out, effusion, constriction. That timing and presentation strongly point to C. Delayed or chronic radiation pericarditis. Acute would be much earlier, CAD presents differently, and while cardiomyopathy is possible, the constriction points strongly to the pericardium here.
Correct. Okay, question 2. Which of the following is the most characteristic, the hallmark type, of cataract induced by ionizing radiation? Is it A, nuclear sclerotic, B, anterior cortical, C, posterior subcapsular, or D, zonular?
Ah, that one's straightforward based on our discussion. It's C, posterior subcapsule. That specific location and type is the classic finding linked to the radiation damage mechanism in the lens epithelial cells.
Exactly. Question 3. According to the recent updates from the International Commission on Radiological Protection, ICRP, the threshold equivalent dose for observing radiation-induced lens opacities after a single acute exposure is now considered to be approximately A, zero point zero 0.05 gray, B, 0.1 gray, C, zero point 0.5 gray, or D, 2.0 gray.
And that's the new number we highlighted. The answer is C, 0.5 gray, much lower than the old 2 gray value.
Perfect. Last one for the blitz. The primary cellular targets, the cells that radiation initially damages to kick off radiation-induced cataract formation, cataractogenesis, are the A, mature lens fibers, B, cells of the lens nucleus, C, corneal endothelial cells, or D, epithelial cells in the germinative zone of the lens.
Right, got to trace it back to the start. The key targets are those actively dividing cells. So that's D epithelial cells in the germinative zone of the lens equator.
Nailed all 4. Excellent. Talking about that revised lens threshold really does highlight something important, doesn't it? That our understanding in radiobiology isn't set in stone.
It's a perfect illustration, yeah. That change didn't come from one single eureka moment. It came from carefully gathering more data over longer periods, looking at lower dose exposures, using better detection methods. It just shows that science evolves.
And it really underscores why we need to pay attention even to seemingly low doses or scattered radiation, especially for sensitive tissues like the lens.
Absolutely.
Yeah.
It also highlights why ongoing research into low-dose effects, maybe even bystander effects in normal tissues, is still really important. We're always refining things.
We are indeed. Okay, this has been a fantastic, really thorough session. Let's just quickly recap the absolute key takeaways one last time for the heart, kidney, and lens late effects.
Sounds good. So for the heart, think delayed effects, often years out. Spectrum includes pericarditis, cardiomyopathy, accelerated CAD, valvular problems. It all stems from that initial endothelial damage leading to chronic inflammation and fibrosis.
Right. For the kidney, radiation nephropathy. It's progressive, shows up months to years later, damage across the board, glomeruli, tubules, interstitium, TGF-beta fibrosis, vessels, and darteritis obliterans. Clinically, watch for that stubborn hypertension and the slow decline in GFR.
Yep. And for the lens, the classic is the posterior subcapsular cataract mechanism. Damage to those dividing epithelial cells at the equator, they migrate weirdly and pile up the back. And the big news, that new, much lower acute threshold of about 0.5 gray from the ICRP.
And the clinical significance of all this is just huge, isn't it? These late effects can dramatically impact quality of life, sometimes even survival.
No question.
Which is exactly why understanding the biology, adhering to dose constraints, and appreciating the fraction size sensitivity of these low alpha-beta organs is just fundamental to safe and effective radiation oncology practice.
It really is the radiobiological bedrock that informs so much of what we do every day to try and protect our patients, not just during treatment, but for years and decades afterwards.
So just a final thought to leave everyone with. We talked a lot about these late effects appearing years or decades later. How might the treatment techniques we're using now, things like protons, more sophisticated IMRT VMAT, aiming to reduce dose spread, how might those changes potentially alter the types or the frequency of these specific late toxicities that we'll be seeing manifest 10, 20, 30 years from now? Something to keep in mind as you follow patients over the long haul.
That's a really interesting point to consider for the future.
Definitely. Remember, you can find more resources, including practice oral boards, over at redonscismartlearn.com. And please subscribe to Rad on Sci Smart Reviews so you don't miss our next session. Thanks so much for tuning in.